There are a few side effects of the analogs that we need to know about. It's well understood. They're very safe. But we always have to talk to the kids about the first month that things are going to speed up. So the breast could start growing a little bit more, even faster than they were growing before. Or the genital changes in assigned meals could happen a little bit faster than they thought. They might get more erections. We have to warn the kids. First month might be a bit rough, but for sure this stuff will work after a month. There is about a 5% risk of local reactions, which can sometimes be severe. So we've seen both in our trans population and our precocious puberty population, about 1 in 20 kids develops a local reaction that looks like an infection. So it looks like an abscess. It can be like pussy, require draining, very painful. It doesn't usually happen with the first injection. It happens after the second, third, fourth one. That requires you to stop using this medication. You might be able to switch to a different long-acting drug. We were switching to the daily preparation for a while. That's now off the market here. But that's something that you have to warn folks about. If you're just about ready to get your first period, this can do it because it can drive your estrogen up and then it can drive your estrogen down, and that can set off. And of course, the very first patient I treated in 1998, that's exactly what happened. And we didn't really think about this back then, but the poor kid was out of town, had his first period, and just ended up in a bad place. So something that we have to warn the kids about. So one of the biggest issues is that if you think about, we haven't probably heard lots about surgery yet, but if you think about vaginoplasty, the creation of a vagina in an assigned male, you need tissue, genital tissue, to create that vagina. And if we are taking a 11-year-old boy who does not have a lot of genital tissue and blocking puberty right there, we're preventing the growth of the vagina for down the road, right? So we tend to, in assigned females, as soon as breasts start growing, if everybody's happy, that's when we would start. In the assigned males, we have taken more and more to letting things go for a little bit so that we get a little bit more genital growth, but then we have to stop generally before the kid's voice starts to change. And as Marshall mentioned, that's one of the first things that happens in male puberty. 3, 4, 6 months in, the voice starts to crack a little bit. We have to stop things there because none of the kids want a deepened voice. But we just talk about we're growing your vagina, and most of the kids can hang in there a little bit. Sometimes we just can't. We just have to stop the kids, and then it's up to the surgeons to figure out how to do that. And we know that this is not perfect. There's lots of stuff that obviously teenagers, their brains are changing, they're unwiring, they're rewiring. And if we've started one kid unwiring and half rewiring, and then we change their puberty the other way and we're unwiring, so people have been trying to, the Dutch in particular, have been trying to figure out what this does for kids' brains. There's not been any really good evidence that we're doing anything terrible with their brain. But the things I think we kind of see how the kids are doing anyway. They're often super unhappy because they're in the wrong period, the puberty. Then they go out of puberty. Then they go back into puberty. And they seem to do reasonably the same as their friends, but we're not looking at their IQ and their learning ability and lots of other things. The other biggest problem with the GnRH analogs is that normally puberty is a time of putting the calcium into your piggy bank. So this is how we explain it to families. You've got a piggy bank for your calcium. You better get it all in by 25 because at 25, you're going to live off that piggy bank. And particularly if you're trans feminine, you're going to come off your estrogen someday and you're going to be at higher risk for osteoporosis. So the puberty blockers slow that calcium accrual back into the bone quite a bit, back to the prepubertal level. And we do know that even if you look at people now at age 22, this is the Dutch folks and now other folks, even at age 22, if you've done all of this and you've gone off and then you go back on the hormones that you want to have, you have not caught up by age 22, which is about the time you need to fill up your piggy bank. So this is a concern that not everybody is getting their piggy bank completely filled up with calcium. And this is just...
And my question is whether you have any information or studies or a sense for how different or how the gonads would be affected from a fertility perspective if you start puberty blocking at attainer stage 2 versus later, and how you advise your patients and their parents on making a decision from that perspective.
Yeah, I think that's the hardest part of what I do. Because of course this is not what's in the mind of a 13-year-old or 15-year-old or even a 17-year-old, because, babies are icky and they poop and ugh. And, you can just go to a store and adopt later on, right? They're just like there in that story. So kids have zero idea about their fertility, right? So, an assigned male has to get to a point in puberty where they're making sperm, at least in today's technology, right? So that's, age 13, 14, 15-ish. So if you're turning puberty off before that, then they go through female puberty. Then they choose to do semen, use their sperm for whatever. They would have to come off their estrogen, go back into male puberty to the point that they're producing sperm, which would be a lot of virilization.
Yeah.
So that's something we have to talk about. For assigned females who are having periods, when they go on testosterone, we know that there's a very good chance if they come off, and particularly those who are having regular periods, if they go on their testosterone, come off their testosterone, that their periods come back relatively quickly, and they can donate an egg or get pregnant, whatever, relatively straightforward. If you were to start,
At 10 or 2, it's not the case.
if you were
though.
to start at, early in a reproductive age in an assigned female, again, that person would have to come off their testosterone, go through female puberty, probably grow breasts to do that. Now, there might be ways around that as far as stimulation with gonadotropins like what the fertility folks do, but I don't believe that that's like a fixed thing yet. That's easily available and is even slightly affordable. So you can freeze eggs and then later use them, but that's still a very early kind of technology that's quite expensive.
But the eggs that you would freeze at 10 or 2, are they even fertile?
So, a little bit of what we know is from like little girls who get cancer, right? And they try to do whatever they can in a very fast fashion to preserve that girl's fertility for down the road after she's cured from her cancer. I don't think that lots is known about that still.
Yeah.
For say a 10-year-old assigned female, I don't think we know.
And the complexity in the U.S. context is that for a lot of folks, this would not be covered, and so.
Right, oh yeah, no, it's all,
Yeah.
it's all self-pay, exactly,
Yeah.
here as well. Probably, I think in Europe, there are places, maybe people know that's like sort of more part of the healthcare system, but here, that's all would be private.
Okay, thank you.